All right, welcome everyone. We'll get started here in a moment as people filter in. Feel free to let us know where you are tuning in from in the chat. All right, Karen's from Connecticut and fastest on the keyboard. Oh, there we go. Ann's in from Sharon. Mary's in from Seattle. Arash is in from San Diego. Hey, Chris Boyce. Welcome. Kendra Tucker from Montana. Janet Nisbet from Ontario. We're going international. Nancy from Mandeville. Mandeville where? I don't know. I should know that. Tammy from Sarasota. John Gall. Welcome, John Gall, our good friend. Right. Number is slowing down, so I can probably start because we only get so much time with Dr. Cantu, the living legend. All right, so hello and welcome to the Concussion Legacy Foundation webinar, How to Approach Suspected CTE Q&A with Dr. Robert Cantu. I'm Dr. Chris Nowinski, co-founder and CEO of the Concussion Legacy Foundation, and thank you for joining us for the fourth webinar of our CTE Awareness Month series. CTE Awareness Month is a great month to get more involved. One way to do that is to sign up to participate in clinical research. We are continuing to announce new studies, including one very soon. So if you're interested in participating and being notified when new research opportunities arise, sign up for the clinical research registry at pledgemybrain.org. The link is in the chat, and I know some of you will be excited to know that the type of former athletes we're recruiting will be expanding starting next week. Today, I am pleased to welcome Dr. Robert Cantu to answer some of your questions about approaching suspected CTE. This webinar was inspired by the dozens of questions we've received all month long. To kick off today's discussion, Dr. Cantu will be giving us a brief overview on the signs, symptoms, and treatment of CTE. Many of the views discussed today can be found in his 2019 paper, Management of Chronic Traumatic Encephalopathy. A link to this paper can be found in the chat. Following his presentation, we will move into your questions and get through as many as we can. If you haven't already sent one in, feel free to add it to the Q&A box at the bottom of your screen throughout our discussion. We will be recording this webinar and plan to send it out to the emails you registered with, so don't worry if you miss a section. We will also post the recording on our social media page as well, so if you don't already, please be sure to follow us. Now, it is my pleasure to welcome my friend and colleague, Dr. Robert Cantu. Dr. Cantu is co-founder and medical director of the Concussion Legacy Foundation. He's also the head of the Cantu Concussion Center, where he also sees CT patients. And he's a professor of neurology and neurosurgery at Boston University School of Medicine. Dr. Cantu, over to you, sir.
Chris, it's good to see you, and it's fun to participate in this webinar today. As I think most of the people in the audience know, CTE is something that can only be diagnosed with certainty after someone's died and their brain is examined for the special protein called tau. But there are two different recognized syndromes of CTE. The first, the classical one, is normally something that hits people when they're in their late 50s, mean age of 59, and there are three different baskets of symptoms. The classical group, cognitive symptoms are the most significant, and of the cognitive symptoms, it's primarily difficulty with recent memory and primarily difficulties with executive functioning, which is essentially problem solving. In addition, there may be difficulties with behavioral dysregulation, which is manifested by impulsivity, irritability, and explosivity, the short fuse syndrome. And also, these individuals may have the third of the triad of symptoms, which are the emotional symptoms, which are predominantly depression and anxiety. This group of individuals, because the mean age of onset of symptoms is 59, has gone through their period of life, whether it be just college or college and then a professional career, finished taking repetitive head trauma, and then gone on for 10 or 20 years before they develop the cognitive symptoms and the behavioral and emotional symptoms that make up the triad of CTE. So this is a group of people that is somewhat advanced, but quite young to be getting the dementing type symptoms in terms of young for Alzheimer's disease. A second group of individuals that does not have primarily cognitive problems, but has a much earlier onset of symptoms, mean age of 35 years, is thought of as the behavioral and mood form of CTE. These individuals usually don't have cognitive problems and usually don't go on to dementia, unlike that first group that I described that does have very severe cognitive problems, and usually as they age into their 70s and 80s will develop dementia before they die. The behavioral mood group is much younger, and they have a much more predominance of the behavioral dysregulation issues, the explosivity, physical and verbal explosive reactions, and also a very significant problem with depression and anxiety in many of them. And this group also has a very significant risk for addictive behaviors, both in terms of drugs and in terms of other forms of problems. When we think of CTE, it's true that we can't have a therapy that gets at the underlying tauopathy problem of CTE, but we do have management therapies that are largely used in other forms of neurodegenerative disease, which also can be applied to CTE, which allow us to slow down the progression of symptoms, reduce the symptoms or mitigate or not necessarily totally eliminate, but make them less severe and certainly make the quality of daily life much better. And I'll just mention them now kind of by name, and then as we field questions, I'm happy to get into a bit more about what each of these therapies are. But two overriding and general therapies that we use for all people with suspected CTE or other neurodegenerative disease are, first of all, exercise, both aerobic and resistive exercises. This has been shown now clearly to have a positive effect on our cognitive ability and our general overall health. And the second is diet. And the diet is the Mediterranean type diet, which is predominantly monounsaturated fats, high in omega-3 that's found in plants and fish predominantly. And so it's a diet that's very high in fruits and vegetables, fish, and to a certain extent, white meat, and very little red meat. Those are two therapies that basically apply to everybody that is suspected with CTE. And then there are other therapies that are directed specifically to the types of problems that the individual may have. In other words, if cognition is a major issue, as it is in the classic CTE individual, cognitive therapy plays a very significant role, including education and symptom management and increasing cognitive endurance. For the mood and behavioral issues with CTE, there are therapists that are involved with cognitive behavioral therapy for the anxiety aspect of it, relaxation techniques, meditation is found to be very useful, and mindfulness also can be a significant factor. If there are ocular issues, blurred vision, double vision, then ocular therapy would be prescribed. If there are balance issues, vestibular therapy would be prescribed. If there are other motor problems such as ataxia or rigidity or Parkinsonism, then specific motor therapies would be used as well. All of these individuals suspected for CTE should be undergoing an endocrine workup to be sure that the symptoms they have are not contributed to or exclusively due to pituitary dysfunction, which is often present in individuals with sustained repetitive head trauma. Those are the therapies that we direct toward the symptoms of CTE. If the therapies themselves do not alleviate the symptoms satisfactorily, then there are medications and pharmacology that also can be used to treat and reduce the symptoms. Probably the most important thing to understand with regard to the pharmacology, though, is that we first want to reduce, or if we can, eliminate virtually all medications that these individuals might be on, especially anticholinergic medicines, antihistamines, narcotics, muscle relaxants, benzodiazepines, and sleep and sedative medications, because all of those medications can contribute to cognitive impairment. For individuals that have primarily memory issues, we use the same medications, the cholinesterase inhibitors that we use in Alzheimer's disease, Aricept and Exelon and memantine. And for therapies, in terms of pharmacology, for apathy, the levodopa medication, Sinemet, are used. For attention issues, we use the neurostimulants, methylphenidate group being the biggest one, the Ritalin, the Adderall, the Concertas, Strateras, and the amphetamines. For treatment of depression, it's largely antidepressants, with Zoloft and Lexapro being very widely used. If depression is coupled with anxiety or apathy, then Effexor is often used. Bupropion is used when that combination is present as well under the name of Wellbutrin. And all of these individuals with depression, exercise and mindfulness is a very big part of the treatment as well. If pseudobulbar affect issues are present, that is inappropriate laughing or crying, Nuedexta is the medicine that we normally use in that situation. If agitation is a major issue, we try not to use medication and rather reassure, relax, reconsider, and redirect individuals, identifying what is causing the agitation. But if that's not effective, then the medicines that are most effective and most used are Risperidol, Zoloft, Lexapro, and Nuedexta. So the treatments for CTE are treating the symptoms, treating the signs, trying to make them less with first therapies, and if that's not effective, then therapies plus medication. And with that brief overview, I'm happy to hit the questions.
Thank you, Dr. Cantu. So that's a nice overview and really a lot of the high points of the paper. So when we send this to you, feel free to watch that again and slow it down and understand a lot of the specific things, but we'll dig into some of these now as we get to your questions. So there were a few dozen sent in advance. And so I'm going to start by talking about the questions around symptoms, and then we'll get into different treatments again, and then we'll get into some things around imaging and the future of research and where this is going, and how do we diagnose this in living people with accuracy. So one question I thought was interesting from Karen, considering that overview, is that people are wondering, is CTE just sort of a straight line decline, or do people plateau for long periods of time, or do people get better from certain symptoms over time? So what's your perspective on that, Dr. Cantu?
Well, we have people that have had stage 2 disease that were in their 80s when they died. So not everybody deteriorates rapidly, and it's possible that some individuals may show very little decline until very, very late in life. But then again, there are individuals that have rapid, precipitous decline within 4 or 5 years of the onset of symptoms. So it's a little bit like post-concussion syndrome or persistent post-concussion symptoms. Each one is unique. Each one can be a little bit different. Generally speaking, it is a decline over time. And if it's not a decline over time, or if you see some improvement, significant improvement that's not related to therapies, you might be wondering whether some other disease process is going on.
And it's probably worth saying too that you've seen patients in their 20s, 30s, 40s who had some aspects of these symptoms, whether they were mild cognitive symptoms or behavioral issues, that with proper medication actually improved and stayed there for a very long time, right?
Yes, absolutely correct. And we're not even sure in all of those cases whether they really had CTE, but no question about being able to improve the symptoms and your quality of daily life with appropriate therapies and appropriate pharmacology if needed. Definitely happens.
Yeah, I mean, now that we've been doing this together for over 15 years, we've had the experience of seeing people who came in who very likely could have had CTE, former NFL players with long careers, but who thought they were spiraling. But with treatments you've given them and the support by other people, we've seen them not only maintain but get better. And I still, see them every year at the Super Bowl.
Chris, I think that's a very important thing that you mentioned. It's primarily the young group with the behavioral mood issues, which we do see improvements that are sustained for a very long period of time. The more classic group with the cognitive problems being the major issue. Though you can improve performance, it's not very often that we see that group significantly improve and then maintain it for a long period of time.
Right. Now, how about alternative diagnoses that people get when they might have CT symptoms? Can it resemble a bipolar disorder?
Well, yes, there's no question that the depression in CTE, if there's mania with it, it does mimic bipolar. It's also important, I think, to understand that you can have bipolar and you can have CTE too. It's not exclusive. If an individual has bipolar disorder, plays enough football or whatever, boxing, whatever the sport is, with enough repetitive head trauma, picks up CTE too, you kind of have two things that are additive. Usually in that situation, the bipolar is going to be recognized when they're growing up and when they're quite young, and it's not going to be delayed until they're in their 30s, 40s, or 50s. But there's no question they can be additive.
Catherine S. wants to know if you can discuss sleep maintenance, how sleep can be affected, staying asleep, returning to sleep. What are you seeing?
Yeah, with head trauma in general, say concussion, very early on, meaning the first day and the next day or two, normally people sleep more than usual and have no trouble getting to sleep. But as time goes on, if they have persistent post-concussion symptoms, and if they have persistent post-concussion symptoms that involve sleep, it's almost always trouble falling asleep and sleeping less than usual as a result of that. And that's the same thing that we see with CTE. We find individuals have difficulty falling asleep quickly, and we have people with difficulty staying asleep.
Do you want to touch on REM behavior disorder?
Well, we do see it with CTE, without question, individuals with movements of the arms and legs while they're asleep. The individual themselves aren't so aware of it, but if you ask their partner, wife, significant other, etc., they will definitely give that history. There's no question that Thorstein has now put out a very, very nice paper about the neuropathology of CTE and where he thinks those REM behaviors are coming from in the brainstem.
Right. And then you sort of touched on this with some of the older people with early stage CT, but Karen C is wondering, what's the oldest a patient has lived while still having some quality of life? And I think this is an important answer for people to hear.
Well, I think we've had people with CTE in their 80s, and some of them have really had pretty good quality of life through their 70s. And so they are the exception. They're not the rule, but it does happen.
Yeah. This is an interesting question in the Q&A from Midge Adams. What is your advice for people that have the symptoms but aren't aware of having the symptoms? How do you broach that issue as a family member?
Well, I think it's important that because we can't diagnose CTE with absolute certainty, that we don't have people worrying about it if they're not already worrying about it. Now, the overwhelming majority of people that come and see me, it's not that they're unaware of their symptoms, they're aware of problems, and they oftentimes think they have more than they really have. But for someone who isn't aware of their issues, I would probably talk with another family member to get a feel for what that person really wants to know or doesn't want to know, and certainly be asking them, why are they coming to see me now? What is bothering them, et cetera. And I think it's very, very important that one not at the first time you see somebody, try to jump to too many conclusions. If you follow somebody and it's CTE, the problem may, over time, especially if it's the adult onset type, I mean, the later life type, the classic type, with a mean onset of symptoms at 59, that individual over time is probably going to show progressive cognitive impairment. And there will be plenty of time to talk about other than quality of life issues and so on that we prop them up with when we initially see them.
Is late day confusion or sundowning associated with CTE like it is for Alzheimer's type dementia?
Well, late day sundowning is something that's seen in anybody with cognitive impairment from whatever cause. And one of the issues with cognitive impairment is that your cognitive endurance is limited. And so if you sustain activity, you can't sustain it for as long as you normally would. If you've been sustaining it during the day, it's common that toward the end of the day, you're not nearly as capable of doing difficult things as you might earlier in the day. So yes, we see it with CTE, but it's very non-specific. It's seen in all the dementias.
Okay, and then last question in talking about symptoms. I think it's an important one. What Graham M is asking, any thoughts or theories why younger people diagnosed with early stage CTE are more likely to die by suicide than people with older patients with later stage CTE?
Well, that's a great question, Chris. In my mind, there are several reasons for it. First, that younger age group, the age group with 35 as the mean age of onset, that's a group that is not cognitively impaired in most cases, but is very significantly impaired with depression, anxiety, and behavioral dysregulation. The impulsivity, explosivity, making snap judgments, flying off on the handle, verbal and physical abusive types of activity. That is a risk factor right there for suicide. Secondly, these individuals not only have those types of impairments, but they also are not cognitively impaired and just have the behavioral dysregulation and depression aspects, but also addictive behaviors are very prevalent in this age group and in that group of individuals. When you start mixing in somebody with a significant substance abuse and or alcohol is certainly one of those substances, but I mean, it can be alcohol plus any number of other drugs. That also leads to a situation where individuals can unfortunately wind up killing themselves, but not necessarily have planned to kill themselves, just put themselves in a bad position at a bad time. I think those are clearly factors. There's no question in my mind that CTE is contributing and contributing significantly, because the number of individuals that die at this age are quite high. So it's clearly in my mind multifactorial, with CTE being in the mix.
Yeah, no, well said. It's also always worth adding that the actual relationship between suicide and CTE, is tough to tease out from these postmortem studies. One of the things about a postmortem study is you have to be deceased, to be part of it. And there are, young people just don't die as often as older people. So while older people are dying from dementia, younger people, even healthy ones, suicide is always the top 3 cause of death. So, but I absolutely agree with everything you said there, Dr. Cantu. But we just don't want everyone to think that suicide is an inevitable consequence of CTE. But a question.
And Chris, this is probably a good point to elaborate on that just a little bit. It is not, and most importantly, it cries out for these individuals being under the care of a psychiatrist, or at least someone that is handling their emotional and behavioral issues. And if they are under good care and they're following the care, suicide in almost all instances can be averted. But if they're either refusing care or not under care, then that is a significant risk.
Yeah, and actually, I'll throw one last question before we start moving over to treatment. It's a good one from Margot. What do CT patients actually die from? I think it's probably about end stage CT patients. You talk about failure to thrive and things like that.
Well, they die from a number of things, but certainly, obviously, toward the end, most of them are invalided. Most of them are not infrequently bedridden. And all those things tend to lead to a deterioration of bodily functions. Also, some of them in that classic group are of an age where they have comorbid issues, whether it's renal disease or cardiovascular disease, that it becomes the final event, but CTE greatly contributed.
So moving over to treatment, there's a lot of great questions around treatment. So one that sort of, some of it is the approach to treatment. I see a question from friend of CLF, Paul, talking about, say you've got a 28-year-old family member who you're worried about in terms of long sports career, a lot of head impacts, is starting to show some issues around cognition or behavior. What's the first move?
I think the first move is just a complete workup of the individual. Beside a detailed neurologic examination would be a rather in-depth cognitive assessment. And what you're really trying to do in part is determine whether or not the areas that are most commonly affected with CTE show impairment. And so you do a complete neurologic exam, but you focus on cognition, you focus on vision, you focus on balance, and you focus on symptoms. And so you want to establish whether they have deficits, and if they do, you now have a baseline for this individual to compare what your therapies that are going to be directed toward this individual are at. As part of the workup and that initial assessment, you also are undergoing, as we mentioned previously, an endocrine assessment because you want to be sure there isn't something easily treatable like a growth hormone deficiency or testosterone deficiency or thyroid deficiency from injury to the pituitary gland, and the trophic hormones just aren't coming from the gland. And by simple supplementation, you can now completely reverse the symptoms. In addition, you're going to want to get a baseline MRI, and the baseline MRI is going to have some bells and whistles on it. It's going to have susceptibility weighted imaging, where you can see microbleeds and remnants of microbleeds in the form of not only tiny little holes in the brain, but also hemosiderin deposit. That's consistent, obviously, with a traumatic origin for the symptoms. The MRI may show a cavum septum pellucidum, which when it's of significant size, and certainly when it has fenestrations, suggests that it's of a traumatic origin. So you think that this individual certainly is at risk for CTE. You're also going to look for atrophy of areas of the brain, and specifically the frontal and the temporal lobes with CTE, whereas in Alzheimer's disease, it's more parietal lobe atrophy that you normally see. But that MRI becomes your baseline, and this will be used over time to follow the individual, not in terms of short 6 months or a year, but more in terms of 2 years, 4 years, 5 years. If the individual has CTE, you would expect progressive atrophy. You wouldn't see further enlargement of the cavum because the trauma has stopped.
Yeah, I think it's worth mentioning again what you said earlier, that some fraction of patients, their symptoms are caused by, as you said, issues with hormone levels and other things from damaged pituitary gland, and getting that assessed might be a Hail Mary that actually helps you, change those symptoms. All right, we get a lot of questions around specific therapies, alternative therapies, therapies that lack published evidence. So you want to give short answers to your recommendations on some of these?
Yeah, I think if that particular therapy does not have risk, then I have no problem with that individual doing it if they feel hell-bent to do it.
So how do you feel about things like neurofeedback?
Absolutely fine. Great.
Hyperbaric oxygen.
I don't feel as strongly about it because it's very expensive and there's no proof that it works, other than anecdotally individuals saying they think that it helped them. But if somebody wants to do it and they have the funds to pay for it, I would never say don't do it. But just make sure you do it in a setting where it's a good hyperbaric oxygen chamber. You don't want to have a spark while you're in there.
Photobiomodulation.
Again, I don't know of any risk to it, so I would never be against it, but I wouldn't be prescribing it only because we don't have proof that it works.
Okay, I thought I saw some others, and I'll get to them. Supplements. What about supplements? There it is.
Well, we certainly favor individuals having a very good diet. We check, in addition to the pituitary hormones, that their vitamin D level is adequate. And many individuals, surprising number of people, do have low vitamin D. Vitamin D, if significantly low, can cause cognitive problems. Same is true of B12. So we check vitamin B12. There are a host of supplements that are out there that kind of fit the same situation as hyperbaric oxygen chamber, just not been shown in double-blinded studies to work. I can't be overly enthusiastic with regard to many of them, because unfortunately supplements are not regulated by the FDA. So the manufacturer is not required to state everything that's in that particular product. And sometimes you can have things in a product that are not so good for you, even though the supplement itself is perfectly safe.
I got 3 more. CBD, William wants to know.
Yeah, again, this is the CBD oil itself, I don't have any problem with at all. Take it one step further, and marijuana itself, I can't really recommend that, even though it clearly has been shown to be helpful in pain situations and in anxiety situations as well. We just haven't studied it adequately, and it's kind of a black mark on medicine that something that's so prevalent has not been better studied.
Yeah. How about psychedelics? Do you know of any research being done? Do you think it's could possibly help with symptoms?
Well, I don't know of any research that's been peer-reviewed, double-blinded, but I certainly know that it is being studied currently.
Yeah. And then Mark wants to know about electroconvulsive therapy, which I remember from using our mutual friend 20 years ago. Is your answer still the same?
My answer would be no, because that's like giving somebody a concussion. And I would rather exhaust everything before. That would be, by the way, would be something that would be used in extreme cases of, or considered in extreme cases of depression.
Yeah. Okay. And we have one of our athletic trainer friends. Thanks for your service. Asking about what's the athletic trainer's role when it comes to subconcussion? Do they have one? Is it measurable?
Well, I think they have a very, very important role, a tremendous role. The biggest way to reduce subconcussive trauma is to have more people advocating for not banging heads in practice and finding ways to practice whatever the sport it is that you're doing, but in a way without taking head trauma. And athletic trainers can be and are an advocate for the athlete. And this is one of the areas where I'd love to see them advocate even more.
Yeah, but it's not, because the subconcussive is defined by an absence of symptoms, there's nothing to diagnose, which was part of the question. All right, so we're starting to get wrapped up here on treatment, but there's still an important question. So you touched on it when you were talking about the potential 28-year-old patient, but can you talk a little bit more specifically about specialties that people should seek out? Do they start with primary care? Where do they want to be directed to? Neurology, neurosurgery, neuropsychology? What's the advice?
I think if an individual has issues following head trauma and they have persistent symptoms after head trauma, then that individual should follow up with a concussion specialist, a concussion clinic, or a general neurologist should be able to help them. On the other hand, if the individual has gone and finished their career and now they're in their 40s, 50s, or 60s, and they're having cognitive problems and maybe some behavioral mood issues. So your major worry is, do I have early onset Alzheimer's, or do I have CTE? Then I think it is wise to go to somebody that has experience with diagnosing and managing CTE. That might be a neurologist. It usually isn't the typical concussion individual, but it can be.
Yeah. Okay. And that's a couple specific questions. You mentioned amitriptyline as one of your treatments for potential symptoms.
Yes, amitriptane is very commonly used for headaches following concussion, persistent concussion symptoms. And some of the CTE patients will have headache problems as one of their symptoms. Mood stabilization, does that help? It's not used in the doses that we treat depression with. So it's a tricyclic antidepressant, but we use it in relatively small doses, 10 milligrams, 25 milligrams, maybe up to 50. We don't use it in 100 plus, 200 plus that you use for depression. So if you're using it to treat headache, it's a much lower dose than you would use to treat depression. Yeah, and going back to that question about what doctor to see, the other thing is that there is no CT specialty out there. And so there's going to be lots of different specialists, and we refer to lots of different specialists, whether they are neurologists or physiatrists or neuropsychologists or primary care, sports medicine. It's sort of
it's really a clinical treatment. So feel free to reach out to our helpline, which we'll throw in the chat if you want a specific recommendation of someone in your area. And another interesting question on treatment: CTE has been associated with repetitive headbanging behaviors for people on the autism spectrum. But there's no one has any research or experience treating those patients that you're aware of, right?
No, I'm just aware of the publication about in the literature of individuals with repetitive headbanging behaviors and that happen to be autistic. But I'm not aware of treatments, but I would so I can't really comment specifically on that.
Yeah, it's a difficult situation though. So if you do need help, the helpline on a specific case, please reach out and we'll find you somebody. And then what's the relationship? Is there a relationship between epilepsy and CTE?
No, I don't think we can draw a straight line. We certainly, epilepsy is known to happen after head trauma, single head traumas, more likely to happen after very severe head trauma where there's been disruption of brain tissue and much greater chance for scar tissue to form. But we know just having repetitive head trauma puts you at increased risk for seizures. So I'm not so sure that I can correlate, and because that is correlated with increased risk of seizures. When we have the occasional patient with epilepsy and CTE, I don't really think it's the CTE that's the major issue there.
Right. Okay. Thank you. All right. So let's start shifting a little bit over to diagnosis and biomarkers and all that. Lots of questions there. If you were trying to get an MRI to get a good look at your brain with suspected CTE, are there types of MRIs that you recommend, Dr. Cantu? Well,
first of all, I personally recommend that everybody that's suspected with CTE have an MRI, and that MRI have special packages on it that can look for susceptibility weighted imaging, looking for microbleeds in the brain. Also, the packages beyond the MRI looking for volume averaging. The most prevalent out there is called NeuroQuant, and it simply compares different areas of the brain with normative values. And in CTE, you're particularly looking at the medial temporal lobe, the amygdala, and entorhinal cortex, and seeing if there is asymmetry and certainly below normal expected volumes in that area. I think everybody should have that MRI. Now, beyond that, if you're in a research study, I think clearly it would be useful to have what's called a Flor-Tau-Sapir MRI. This is a MRI that uses a PET process whereby you're lighting up and hooking on to tau in the brain. That can't be used, however, in single individuals with enough accuracy right now. Pooled data will show a difference between individuals with high exposure to head trauma, like a group of NFL players, and controls with no repetitive head trauma that's known. But it's not sensitive or specific enough for a given individual. So I don't have any problem if you're in a research study, these things being done, but I would not have people pay for those studies otherwise.
What are your thoughts on PET scans and their ability to potentially help us diagnose CTE?
Well, they're helpful, but they're not absolutely accurate. So technically, what you should find in an individual that has CTE is you should have low beta amyloid or no beta amyloid on a PET scan for amyloid, and you should have high tau in the PET scan, the Flor-Tau-Sapir scan for tau. It sounds good, but unfortunately, the accuracy of them is not good enough to definitively answer the question in almost all the cases.
Yeah, yeah, and that's a couple of people sort of asked that question on timing. So, advances have been made even in the last few months on understanding markers of CTE in the living by going back, the BU CT Center team going back to look at scans and other tests of people who were diagnosed with CTE postmortem. But how close do you think we are till you are telling a patient, I'm confident you have CTE, or I'm 80% confident you have CTE? You can put a number to it.
Chris, I wish you're absolutely right that the papers keep getting cranked out, but I can remember back to around 2010 and 2012 when we were sitting, you and I and Bob Stern, fielding questions, and when do you think we'll have a specific marker for CTE? And the general answer was 5 years. And then a couple of years later, it's 5 years. And a couple of years later, it's 5 years. We're getting closer, unquestionably. And we know more, unquestionably. And we're getting better with regard to understanding the CSF changes with regard to what total tau and phosphorylated tau and beta amyloid in the CTE. But once again, it's something that allows you to become a little bit more confident that somebody probably does have CTE or not, but it's not anything that allows you to definitively give the answer.
Right. I've changed the answer now that I've seen people make that statement. I like to say, if the research breaks our way, if the studies we're doing now, show that, like, we're recruiting former NFL players to PET scans right now. If when that's published, it may work, right? If it doesn't, it'll take longer. I got to give a shout out to, again, Dr. Steen was the lead author of a publication last week that showed that a specific type of tau is actually different. You can pick up from the bloodstream is different in CT than Alzheimer's disease, right? So you could do a tau ratio blood test. If that works out, you're talking maybe 5 to 10 years. But so part of this and part of everything we do with the Concussion Legacy Foundation is trying to get more shots on goal. That's why I pitched early on, you sign up for the clinical research registry, help us do these studies so that we are, and sign up to pledge to donate your brain if you want to, although I want everyone here never to live long, healthy lives. But help be part of the system that's going to get this treatment. Everything we've learned, we owe to, just over 1,000 families who've donated the brain of loved one, plus hundreds of people who've flown to Boston or San Francisco or our partners to help us try to figure out these tests in the living. But that's a good answer. This is an interesting sort of open-ended question. Mark asked, what does a clinical diagnosis of CTE really mean? And actually, do you want to speak to what CT versus TES?
Well, right now, the greatest correlation with CTE is, do you have the signs and symptoms of either cognitive, behavioral, or mood issues? And then, do you have a very high exposure? We know, at least in football, and that's certainly the one sport where we have hundreds and hundreds of cases, so we're much better able to come to conclusions about what is the amount of head trauma that is most likely necessary for CTE. We know that if somebody's played 14 years of football compared with somebody that's played 4 years of football, the risk for CTE is 10 times higher. And we know that if somebody's played 4 years of football, even though statistically the risk of CTE may be up a little, it really isn't in the sample that we have so far. So if you've only played high school football, your risk of CTE is not up. That isn't to say that there aren't high school football players that have CTE. They did. Almost all of them had many years of repetitive head trauma in addition to their high school years. as well.
Yeah. Is there a genetic predisposition to CTE? What does that mean?
I don't doubt there has to be more probably than not a genetic contribution to CTE. We know that individuals that have identical or almost identical amounts of brain trauma, in some instances, individuals will have CTE, and in other instances, they won't. There have to be protective features. Part of it may one day be found to be environmental, might be diet, and certainly it would be expected that there will be genetic situations that will predispose you to have an earlier onset and more severe type of CTE than someone without those genetic factors. Right now, we're in our infancy of trying to understand that, though.
Yeah, but it's safe to say that, you know, a lot of people like to focus on. I remember reading an article in Australia last week. You know, one brother out of three who all played high-level contact sports appears to, you know, have dementia, and the other ones don't. Or just why two people on the same line, one has CTE and one doesn't. Genetics probably accounts for a large portion of that, right?
I would think so.
Yeah, maybe less so with the brothers. Bad example. Yeah, this is probably a question that isn't for you to answer, but I think it's worth mentioning. You know, Alex asked, if someone has CTE, what kind of long-term options planning is recommended to proactively deal with the risk of cognitive decline? Right.
Well, I think first of all, this individual, we don't know whether they have CTE or not, but if they're at risk for CTE and they have symptoms consistent with it, and those symptoms happen to be cognitive, then the things that should be put in place after you've eliminated endocrine issues and so on, is that individual should undergo cognitive therapies, for one thing. And number two, all of them should be on a proper diet. Mediterranean diet is currently the one that we think is most beneficial, and should be on an exercise program, a routine exercise program. Those are things that virtually everybody at risk for CTE should be on.
Yeah, and I think, you know, the other part to that question is really more of a social work aspect. You know, questions like financial planning, estate planning, power of attorney, medical decisions, that sort of thing, and that is an area that we're learning about. And part of the reason is that we have a legacy family community of now, you know, nearly 1,000 family members of our brain donors who've lived this. And we just were with them a couple of weeks ago in Las Vegas for what we call our family huddle, where we share with them what we've learned from their loved ones, and we sort of build those relationships so we can continue to learn from them, especially, and we're actually actively interviewing them for the spouse experience with CTE, the child's experience with CTE. So that's an area of focus for us here over the next year. We'll be trying to understand some of these nuts and bolts. Okay, your loved one is heading in this direction. What should you be thinking about? And so I know some of those family members are here on the call. We'll look forward to reaching out to you, and shoot me an email if you want to volunteer to be part of that. And I'll just add that the little question came in, what is TES? I apologize for not defining that. TES is traumatic encephalopathy syndrome, or the clinical syndrome that we believe is associated with CTE, that is now in a research phase, but eventually your doctor wouldn't necessarily diagnose you with CTE while you're alive. They diagnose you with TES. All right, so Dr. Cantu, we got a hard stop at 4, so we got 6 minutes. We're gonna a lot of questions have come in that fit all over the place, so I will hit you up with fast questions, fast answers. How do you use exercise to support symptom improvement if minor physical exertion causes headaches?
Well, that presents a problem, but most people will find that exercises that are ballistic in nature, impact in nature, jumping, running, things like that, will produce headache much more than exercises that are like on an ellipse machine, or walking on a treadmill, or walking in water, or swimming. So we try to find non-impact exercises that somebody can do if ballistic exercises produce headache.
Okay. How does one improve cognitive endurance?
Actually, you improve it by working in a stepwise manner with your cognitive processes that you're doing. So it's really just doing the exercises for longer periods of time, working at your computer for a greater period of time, but in a very incremental, stepwise way, not taking big steps up that are going to flare up symptoms and actually set you back.
Our good friend Irene from New Zealand asked about Depakote. Is that ever, you ever prescribing that for any symptoms associated with CTE?
Normally, we haven't used much Depakote. Depakote is a anti-seizure medication, and it is one of the meds that can be used with headaches if headaches are a prominent issue. It also can be used as a mood stabilizer. And so if all else has failed in somebody with issues with depression, anxiety, so on, Depakote can definitely be tried.
Ketamine infusion, thoughts?
It's been used. Again, it's not, I don't think it's like mainline therapy. Again, in somebody refractory to treatment, it might be considered.
Do untreated CT patients have a proclivity to be violent? What's the violence? Is there a violence connection?
It is seen in CTE, that impulsivity, explosivity, physical and verbal explosive behavior. So it's clearly in the behavioral dysregulation triad, part of the triad with CTE. So we certainly see it.
You mentioned tremors, right? So what are medications you're prescribing for tremors? Brent is asking.
Well, it depends on the type of tremor. If it's a pill rolling tremor and it's consistent with other issues with Parkinsonism, such as bradykinesia, which is slowness of movement or rigidity of muscle movements. And the pill rolling tremor is typically this kind of motion when somebody is at rest. Then Sinemet or levodopa is the most common medication that's used. On the other hand, we don't normally use those medications for intention tremors that happen when you're trying to do something like touch your nose with your finger.
Okay, we'll go two more comments here. One, Sherry Carpet asked, what are things that we as family members or people with suspected or probable CT can do to help? Appreciate the question. That's the part I mentioned about signing up for clinical research registry, pledge you donate your brain. Sign up for, we have a CLF champions area on the website. Sign up there, shoot us an email at info@concussionfoundation.org. Let us know you're interested. We'll find something. We are just announced the Resilient 5K if you're in the post-concussion syndrome world to help raise money and awareness. We will have a big 5K around focused on CTE. We'll be announcing very shortly. You can join that to help raise awareness. And then I'll sort of end here with David. So David just wrote in this sort of a good case study of the people that are, people that reach out. I'll be 42 in July, started playing tackle football at 7 through high school, lots of concussions. Families noticed a lot of changes recently, anxiety, uncontrollable, depression, paranoia, concerned it might be CTE. What do you tell this person? And also I'd say, David, please reach out to the helpline and we will find you someone to help you get through this. But what do you tell that person, Dr. Cantu?
But I think he should be worked up, Chris, and thorough neurologic assessment, endocrine assessment, MRI, and then depending upon what his symptoms are, most prominently, it sounds emotional here, they should be addressed. Yeah.
And the answer is, again, we Dr. Cantu, I send a lot of these folks when they're in New England to Dr. Cantu, and we talk to them 2-3 years later with the right medications, the right therapies. That stuff's all in the rearview mirror, right? So it's important to appreciate that those symptoms are all manageable. And it's good to pull in your family, get their support. Obviously, if they've noticed these things, you're talking about it, which is important. So the important thing is, you can get through this, and we'll connect you to a community of people who've gotten through this. But these things can come to a head, and it's important to reach out. I'm glad you're here, and we look forward to helping. So we are out of time. So let's all give Dr. Cantu a big, quiet round of applause for giving us his time and his expertise. I see thank yous coming in from the chat. I appreciate everyone coming to this to learn, share this with your community, let them know we're here to help. If somebody wants a lapel pin, I saw, please reach out to, shoot an email to info@Concussion Foundation. We can get you a lapel pin. But I'll just end with the so thank you, Dr. Cantu. You're my hero. I'll wrap here with a few sentences. If you or someone you love is currently struggling with symptoms of suspected CT, we're here for you. Please reach out to the helpline. It's a URL you see on the screen in the chat. Again, personalized help, whether you're struggling from concussions, PCS, suspected CT, symptoms that could be caused by something else. We will make sure you get to the doctor, get this thing figured out. We've been learning along the way for years about who do people like to see, who wants to see these patients. There's a lot of physicians and other allied health professionals out there to help you, that want to help you. You're not alone, and help is available. So we appreciate you all tuning in. We hope to see you at our next webinar, and take care of yourself.